I'm going to be talking about multidimensional family therapy. But before I go into the specifics of MDFT, I'm going to start a bit with talking about family therapy as well. Starting, we already know that the rate of use of illicit substances worldwide is increasing, and India is no different. And there's a new issue that's been coming up is that the age of using these substances is also rapidly decreasing. So we are seeing a lot of use of illicit substances and alcohol use among much younger population, and them being exposed. Now, when it comes to the young population, we're generally also concerned about preventing development of dependence pattern. It's well known that substances are explored by youngsters, especially teenagers. It's part of them exploring, individuating from childhood towards young adulthood. But at the same time, we have to also keep in mind that there are a lot of risk factors associated developmentally, socially, biologically. And that is why this population, when we talk about the young population, anyone between 11 to 25 is basically at risk. And therefore, a lot of in the West, for the last 2 decades, there's been a lot of talk and there's been a lot of research about what kind of therapies actually would help this population. Now, the reason why there should be a different therapy than CBT or for the regular second wave therapies or the third wave therapies is that this population is unique. It is very different from the adult population. And when it comes to India, it's even more unique because of the cultural, because of the societal and religious variations and impact. Now, also when we talk about substance users, we're talking about comorbidities, we're talking about diagnostic orphans. Diagnostic orphans is something that people meeting certain criteria for substance use, but not for substance dependence. But that doesn't mean that it's not actually impacting their life, or that doesn't mean that it's not impacting their the healthcare services and the society at large. Also, treatment adherence with the young population using substances has always been a challenge, and that's been considered a challenge everywhere. In India, most of the time, substance users do not come alone. They probably don't even come by their own will. They're brought in. So, okay, they've been brought in, they've been prescribed, there's been a management plan, but how do you make these people stay in treatment? Because that's the major issue when we're talking about the young population. So MDFT or family therapy or family-based interventions were primarily devised and researched first with the younger populations to see whether there are outcomes different from other therapies in terms of treatment adherence and then later substance use outcomes. So when we're talking about substance use, there's a different perspective in which we view substance abuse. We often do not see it as the problem, but just the tip of the iceberg. And there are various factors that are playing role in development of substance use disorders or substance abuse. And these are sociocultural factors like exposure to positive expectations and attitudes towards substances, or modeling of substance use behaviors, developmental factors like physiological, biological, social, and psychological changes that are happening during this phase. Also, experimenting, as I've mentioned before, it's also seen as a method of individuation, autonomy, and change. Now, when we talk about individual factors, they involve cognitive, attitudinal, social, temperamental, biological, pharmacological, and developmental factors combined. Also, Dr. Jayan talked about self-medication hypothesis. So a lot of people use substances, individuals that have difficulties with mood regulation, affect regulation, and also users associated with poor self-esteem, low assertiveness, poor behavioral self-control, and there are a lot of individual differences if we see uh, individuals using substances. There are also familial factors which we cannot ignore. Familial factors like modeling problematic behaviors and attitudes by either the parents or by an authority figure, or by the peers or in institutions. Parenting practices also do play a major role. Harsh disciplinary, poor monitoring, and critical kind of practices are usually related with highly correlated with substance use and dependence pattern. School and community are another level. For example, when such individuals are not engaged in school, they have poor relationships with teachers, peers, and they are performing poor academically. That can also be either an indicator or it could also be an outcome. Poor belongingness and attachment to the community and neighborhood, and coming from an unsafe environment. There have been lots of studies talking about this and substance abuse. Now, moving on to what are the evidence-based interventions that are available, are basically family support network, adolescent community reinforcement approach, multidimensional family therapy, which I'll be talking in detail further, brief strategic family therapy, multisystemic therapy, and family behavior therapy. So all of these therapies are actually either family therapies or family-based therapies that have gained recognition empirically, have been tested and found to be effective. So when we talk about family therapy approaches to substances, we talk about family focus and we talk about individual focus. So there will be certain family therapies that will take the entire family as a unit and as the patient, and there will be certain family-based interventions which will take the individual as the focus, but family as the system around it, which also requires modification. Family focus deals with difficulties arising in family cohesion, conflict resolution, emotional expression, and burnout suffered by the family members and the caregivers, single parent or blended families, which is definitely not as high as in the Western countries, but is still a concern, and patients do come from such families. Parent management and family communication, to name a few. There are many other things, but most of them come under these broad categories. Individual focus aims at symptom reduction, obviously, social and occupational challenges that the individual has been facing, skills training, and also the social peer interaction. Now, if you look at it, I have not made symptom reduction as the only focus, because again, I would reiterate that symptom reduction is seen as a consequence of these other 3 or 4 approaches or aims that we fulfill. Now, we're talking about a comprehensive substance abuse treatment model. We are looking into the mental health care services. We are talking about medical and educational services, vocational services, as well as family services offered to the family members who may be having multiple problems, difficulties, pathologies, etc. And in the midst of it is basically a structured assessment process, structured evidence-based treatment tailored for the individual and the family, substance use monitoring program, clinical and case management as we do it. Recovery programs have to be integrated. We can't just leave it after the discharge or after the initial symptoms have resided. And continued care is something that is being highlighted. So most of the studies that have been further criticized have been in terms of, yes, all therapies do show improvement to some extent, but continued care, the treatments and the research done with therapies that show continued care show long lasting outcomes and maintenance of positive outcomes. So, what is multidimensional family therapy? So, there are certain assumptions associated with it, which is environment plays a powerful role in encouraging or discouraging substance use behaviors. And thus, the attempt of a therapist is, or the team is, to arrange these contingencies, these environmental contingencies, in such a manner that the sober behavior becomes more rewarding for the person than using substances or substance use behaviors. And this also takes into account not just substance abuse behaviors, but also associative behavioral problems. So we're trying to focus somewhere at the core, so that the effect comes over to various domains of the person's life. Now, the techniques are based on the operant model, systemic approach, community reinforcement approach. Functional assessment is very important before we start or we assume the kind of therapy that we need to do with the patient. It is about assessing what are actually the needs of that particular client, and therefore structuring our intervention around those needs. Skills training, MET, parent management, communication, and relationship building are all part of the therapy module. So you may think that we're trying to do a lot of things, and it's not really possible. But the point is not to use all of these techniques. The point is that your functional assessment should be very close to accurate. It should come out with the core features that are problematic, and then use some of these integrated techniques to plan the intervention and administer it. So why MDFT for substance abuse? I mean, why a family therapy for substance abuse? Because substance abuse carries with it a lot of dysfunctions in various domains of a person's life, and it affects and the effects can be seen in terms of violent behaviors, be it in the family context or be it in the community, delinquency, psychiatric disorders, risky sexual behaviors, unwanted pregnancies, impulsivity, accidents, head trauma, traumatic injuries, and neurological impairments, school dropouts, which is also one of the major concerns, not being able to keep a regular job or maintain employment, which further causes spillover into other family issues. And this is not the end of the difficulties that people or the families face when there's someone using substances. Now, if we talk about literature that is available to us, there's literature available on family coping, and this study was done by Offord in 1998, where they were exploring different styles of family members and how they cope with the substance use. They found three basic styles, which is either they tolerate it, or they withdraw from the substance using behaviors, or they engage or involve in it, trying to stop it. So there are three ways of coping. The reason why this study is influential is because it also informs us as to what kind of assessments we should be looking into when it comes to family. Further, the effectiveness of multidimensional family therapy has been proven by a couple of RCT studies where 182 marijuana and alcohol abusing adolescents in the age range of 13 to 18 years was conducted. There were three groups. One was MDFT, another was adolescent group therapy, and multifamily educational intervention. All these treatments were manualized, and they were administered once a week. And MDFT showed the most improvement from intake to termination. The outcome was studied in terms of drug reduction, acting out behaviors, significant from the time to the follow-up. So there have been reviews about family-based treatments by Austin et al. 2005, and most of these reviews talk about this most significant and unanimous finding is that treatment adherence has gone up to 90% from almost 30% compared to individual interventions or other psychoeducative programs when we talk about MDFT compared to other interventions that have been available. I'll be coming to this slide in a more modified fashion. Yeah, so we're talking over here about effective components of family-based therapy. So what makes it effective and what are the components of this therapy that have been found in MDFT? So there are things like treatment access being easy, procedures to reduce treatment dropout is there. So this is maintained by basically maintaining telephonic follow-ups and reminders, and making it easier for the patients and their family members to reach out for services. Success in minimizing treatment dropout, providing comprehensive services. When you're talking about comprehensive services, we are talking about medical services, we are talking about legal aids, we are talking about probably family couple services that we might be liaising with the social work team, etc. So being able to give them a holistic treatment is the reason why it's been more effective. Also, it involves a family therapy component that individual therapies don't involve. The focus is always individual and not on the environmental manipulation. Also, there is peer support of non-users, which is a brilliant idea to basically make using peers as role models by engaging them as well into some structured eclectic sessions. Also, the main aspect that has led to the effectiveness of this therapy is that they try to meet the needs of the individual, which may vary from one patient to another based on substances, based on their vulnerabilities, based on their family accommodation, family arrangement, etc. So the take-home message that we have is that in developing any kind of treatment that we are expecting to be effective with patients who are substance users, substance abusers, or substance dependent, ease of accessibility, providing services that are comprehensive, family involvement is necessary. So it is always necessary to have at least one family member uh, who can be part of the therapy process. Parent support of non-use behavior. Also, we'll be seeing a lot of parent users. Addressing some of those within the sessions is something very important and very effective. Helping parents, family, as well as individual develop skills, because we have seen skill deficits in such families and also communication patterns to be faulty. So these are certain things that when we address, we automatically make the living environment of the patient as well as the family member more rewarding and cut down the stresses that will actually lead to use of substances. So I think that I would like to end the presentation with that.